So, good afternoon. It's just an overview about the orbital tumors and approach and management. I have no financial disclosures and no conflict of interest. So, basically, we all say that orbit is a Pandora's box and anything is possible in the orbit. Well, we see a lot of tumors. Sometimes the diagnosis is right there in front of you, clinically as well as radiologically. But then sometimes there are, dicey situations and dilemmas in orbit as well. So basically, a clinical evaluation, imaging is so very important. Systemic evaluation is so important, especially when it's a neoplasia, which is could be a malignancy, and appropriate management is taken care according to that. So depending upon the origin, we have primary tumors, we have secondary tumors, which can be arising from the adjacent in and around structures of the orbit, and metastatic tumors. Now, tissue of origin, we again classify into neural, vasculogenic, lymphoproliferative, lacrimal gland, histiocytic, bone, and cartilage. Now, a very broad classification, another, the third classification is depending upon the location. It could be intraconal, it could be extraconal, or it could be both intra and extraconal. And this is the list of tumors that we come across. Now, going on, we'll go from pediatric to few important tumors from pediatric to adults. So this was two children, almost the similar age group, 1.5 years of age, presenting with dystopia. This child has a superior dystopia, and this child has an esotropia, a medial dystopia. So both these children has a space occupying lesion in the orbit. So any child, 1 year of age, 1.5 year of age, who comes with a proptosis, the first thing that you would think of, especially axial proptosis, but in this child there is an abaxial proptosis, but the imaging shows it's optic nerve glioma. And well, this child does have other systemic features like cafe au lait spots, etc., in the body. Now this child doesn't have that, and this is the tumor that is sitting in there, a large cystic tumor. So orbit teratoma is something that can present in a child. So in this child we would go for surgery and excision biopsy. But whereas in this child, obviously it's an optic nerve tumor, you don't go and excise it, and diagnosis is by imaging, clinical and imaging. So there are certain non-surgical approach that we use in these children, that is systemic chemotherapy. So this child underwent surgery where there is a complete excision of the tumor, and this child underwent systemic chemotherapy. So depending upon what tumor you're dealing with, if it's an well defined tumor which is excisable, definitely it's in toto excision. Otherwise, certain tumors like this, systemic chemotherapy really helps. So just giving you an update. So this is an update in optic nerve glioma. There are times when optic nerve glioma is observed and not done anything. Well, it does progress, although it's a benign tumor. It does this child came with bilateral optic nerve glioma. So if we don't treat it and stop the progression, it can actually grow from one eye to the eye, the worst eye to the better eye. The child's worst eye was the left eye, and the right eye was a seeing eye. So in order to stop the progression, definitely there has to be a treatment. So the child received vincristine and carboplatin, whereas MEK inhibitors is something which is very new, and even anti-VEGF bevacizumab is considered. So we don't want to land up in this situation. This child at 8 years of age presented with optic nerve glioma with a progression, and it does progress. So this was how the child came with. At this point, in fact, the intracranial part of optic nerve glioma was also progressing, but the parents were more concerned about the cosmesis in this child, where the eyeball has really bulged. And I would say this was one of the largest tumor that I have excised, so enucleation has to be done, and a implant and prosthesis was fitted. So whenever you see a child with optic nerve glioma, there are treatment options. Consider treatment for these patients. Now, dermoids is not only pediatric. It usually presents due to the sequestration of the embryonic epithelium between the orbital bones, and it's usually seen in the medial or the lateral portion, and it's very typical. There is no dilemma about the diagnosis. In fact, there are situations where it may be a deep dermoid, and it could be a dumbbell dermoid which is extending to the temporal fossa also. So imaging is very important to rule that out. And most importantly, now taking a decision whether you want to excise it when the child is small or just wait date, well, in our practice, we would actually excise, even if it's a smaller child, because there is a chance of rupture if at all there is a trauma. There can be inflammation and pain and swelling in these children. So, and obviously, if it's a smaller one, cosmetically, it's much better. So, I would go for a lid crease incision over here and take out that small dermoid from there. Now, this is Dr. Rajni is here, and it's my favorite case. And she had referred this case to me, a 10-year-old girl, proptosis diplopia, rapid progression. In fact, it looks like a subconjunctival hemorrhage with a trivial trauma that the mother gives. You can see severe hemorrhage in the, conjunctiva as well. Her imaging, this is what it shows. It probably could be an inflammation or even a neoplasia. But what was very, very striking is this triradiate location of the tumor. And, it's extending to the temporal fossa, intracranial extension, and it was sitting in the lateral. Well, it could, initially when it came, I prayed that it be an inflammation and abscess of the lateral rectus, which is extending to the edges and structures. But whenever we have a triradiate lesion, be it a pediatric patient or an adult patient, these are the things that you have to keep in mind. As far as neoplasia is concerned, neuroblastoma, PNET, sphenoid wing meningioma in adults, plasmacytoma in adults, leukemia in children, or even lymphoma. So we went ahead doing an incision biopsy, and it came out to be an Ewing sarcoma, PNET, in this child. Luckily, systemic involvement was not there after bone marrow biopsy and PET scan. She underwent a multimodal treatment with, chemotherapy and radiotherapy, and she's probably doing well. Ma'am, is she coming to follow up with you? Yeah? No, not with you. Yeah. You saw her once. I think they're going at, yeah, I think she's doing well now. Yeah, it's been 4 years now. Thank you, ma'am, taking care of her. 11-year-old boy, history of fall, referred as a case of retrobulbar hemorrhage. In fact, to an orbital surgeon to probably drain the blood or something, and his vision is reduced. Well, it's just not the left eye. If you see here, even there is a puffiness of the right eye over here, and he looks very frail and weak, and there is, the swelling over the maxilla as well. So, well, when a child present with this kind of an ecchymotic proptosis, the first thing that goes in our mind as a clinician is a leukemia. So the first thing, we don't even go inside. The only thing that we do is basically do a peripheral blood smear. And if you see the imaging, you can see a lesion over here, and there is a lesion growing in the other eye also. So it was a granulocytic sarcoma, and it was AML non-M3, which was really bad prognosis, and the child died. Another thing with ecchymosis is metastatic neuroblastoma. This was a child who was referred from Bihar, treated for orbital cellulitis, rapidly progressing. This bulging happened in 10 days, and in the train journey that they had, 2.5 days, they say it was like really, really bad. All right. So, well, when we did the imaging, it was not looking like an orbital cellulitis. There is a space occupying lesion over here, a large one. Went ahead. So, in a child presenting with this kind of a lesion, obviously PNET is something that we would consider. Rhabdomyosarcoma is usually seen in the first decade. Slightly older child, a 3-month-old child, is very, very rare. But when I went inside, it was almost like a well-defined lesion. So, I didn't do incision biopsy. It's so very important in rhabdomyosarcoma as a surgeon that you give maximum surgical clearance. If you can take out the entire thing, the prognosis is much better than leaving behind some lesion. It came out to be an rhabdomyosarcoma embryonal, as I told you, in the first decade of life. But there are extremes also. This was a 23-year-old, who was again referred from Yemen. And you can see this was how she presented. And January, her proptosis was very subtle. She was waiting for the visa. And by the time she reached me in April, it was this situation. It's a recent case. A large lesion. Well, when I didn't think it was rhabdomyosarcoma, because she was old. But then I went ahead, removed the entire lesion. She had a corneal perforation also even before she visited us. We couldn't salvage the eyeball and the vision. And then eyeball is still there, but vision is not salvageable. And this was a large tumor that we excised. But this is what I want to actually see. Rhabdomyosarcoma, if you really suspect, pull out the tumor entirely. And why would I say that? As you can see here, we group it. Group 1, with good prognosis, is tumor completely removed. Okay. Now, Group 3 is gross residual tumor. So it actually prognosticates what is the tumor status. So it's very, very important. And we have the multimodal treatment protocol. I'm not going into that. Now, going into adults, the most common tumors are the intracorneal lesions, as in this lady and this patient, where the vision had dropped, with optic disc edema into 6/16, both the patients. And you can see an intracorneal lesion. But, well, the lesions are different. This is my kind of yellowish in color. This is a schwannoma, and this is very, very reddish like a strawberry, and it was a cavernous hemangioma. So we excise it. But there are situations when it's present in the apex of the orbit. We usually don't take it out because that can compromise the visual compromise in these patients. So gamma knife radiotherapy is something that we would sort. This patient with a very subtle proptosis in the right eye, first thing that we do as clinician, for us, it's just not orbital evaluation. We also dilate all these patients with orbital space occupying lesion. And this is what we saw, the coleochoroidal shunt. Coleochoroidal shunt, proptosis, what would be the diagnosis? Meningioma, yeah. Optic nerve meningioma. All right. So we did an imaging, and you can see that there is thickening of the optic nerve. Now, meningioma has an other nature also, which is called the sphenoid wing meningioma. So the optic nerve will be spared, but the sphenoid will be involved. There can be orbital lesion, space occupying lesion laterally, and it goes to the intracranial aspect also. So this was a patient. So both the patients, the treatment is radiotherapy. That's what we do. We try to debulk. In optic nerve meningioma, we don't do any biopsy or excision, but in a sphenoid wing meningioma, we try to debulk. Sometimes if it's too large, we take the help of a neurosurgeon as well. And both of them got radiotherapy, a linear accelerator. Well, I'm just showing this patient for two reasons here, 52-year-old lady, because this was the first orbitotomy that I did when I was a fellow at LV Prasad. So it's my favorite patient. A large orbital, a space occupying lesion in the lacrimal gland. She had undergone a surgery elsewhere earlier where the diagnosis was not really confirmed. A large lesion. When orbital, lacrimal gland tumor, it has been a long standing. So malignancy was ruled out, probably a benign lesion, but we always want to take it out in toto. We don't want to take a biopsy of a pleomorphic adenoma and leave it there and then cause a malignancy later. Well, the entire tumor was taken in toto. My first case in my career, which started as a fellow, this came out to be a solitary fibrous tumor. Now there are vascular lesions. This is a lymphangioma over here, venolymphatic malformation. So venolymphatic malformation, we don't go and surgically excise it nowadays. The treatment is bleomycin. So this is a patient where I have extended my application of bleomycin apart from venolymphatic malformation to varices. So I do inject bleomycin in varix. This is a patient with Valsalva's where it is extending. I'm going to go quickly through. So this is how I inject bleomycin. There is a three-way valve. I aspirate the blood and then I inject through another port. So this is how we do the procedure. Well, vascular lesions, this is a keratico-cavernous fistula, low flow in this gentleman. So there is a newer classification. This was for the postgraduate student when we always talk about orbital vascular anomalies, ocular vascular anomalies. Talk about ISSVA in your examination. I'm not going to talk to you elaborately. Now, ocular adnexal lymphoma is a very important topic here because this is the most common orbital malignancy that we come through. It can be in the orbit, it can be in the muscle. As you can see here, there is multiple muscle involved in this patient. Bilaterally, it can be in the lacrimal gland. So this patient had a regional lymph node metastasis, no systemic metastasis. He underwent systemic chemotherapy. We do PET scan to rule out that. This patient had only ocular involvement. What I did for her was something very, very new. What I did her for the boom radiotherapy. Boom radiotherapy is a ultra low dose radiotherapy. So what we do, traditionally it is around 25,000 centigrade that we apply, but here it is like 400 plus 400, and that is what, a very low dose. And also she received an intraorbital rituximab injection because it was CD20 positive. So this is the panel of IHC markers that we do for orbital lymphoma. It's just not telling that it's a lymphoma or a lymphoproliferative lesion. We need to typify it. There are so many markers that you do to find the, the commonest to the rarest. And so this is a 52-year-old gentleman who presented with this lesion. Initially it was thought it could be a meningioma, a sphenoid wing meningioma. Even I thought so. He was, came for a second opinion. I went ahead doing a biopsy, and this came out to be a lacrimal gland adenoid cystic carcinoma. And why is that important? Because this is the most lethal and most treacherous malignancy of the orbit. We did publish recently my work with Dr. Santosh Unawa, my mentor. Seema was also part of this work, and we had spoken about the multimodal treatment protocol, where we actually initially do neoadjuvant chemotherapy, consolidate the tumor, excise it, radiate it, and give adjuvant chemotherapy with improved survival and globe salvage. So orbital neoplasm and biopsy, last two slides. Non-surgical approach, yes, we have lesions where we approach non-surgically. Incision biopsy in those cases where we want diagnosis and excision when it's a well-defined lesion. There are situations where you don't even go inside. Like, when you're suspecting a granulocytic sarcoma in a child, it's just peripheral blood smear, gamma knife radiation in risky lesions in the apex, and stenting and coil embolization in vascular lesions. Yeah. Thank you very much. So let us not be scared about these lesions. If we can manage it well, please do manage it appropriately, and the patients are going to have a good outcome. Otherwise, refer it. Thank you so much.